new friends. So we're going to begin with the nomenclature or the definitions. We're going to speak about organisms, patterns of spread, locations harkening back to those definitions, then how infections look like on radiography, nuclear medicine, and MRI based upon those locations. And if we have time, complications of infections, disc-based infections, and tuberculosis. So this is a case of a spinal infection. Note the preservation of the disc space, which will help you distinguish TB, which this is, from typical pyogenic infections. So we begin with the Latin, and the root of the word is the part of your body. The end of the word, the suffix, is always itis. Itis means inflammation. Now, in certain parts of your body, the only inflammation is infectious. If that's the case, we just say osteomyelitis. Osteo meaning cortex, myelo meaning marrow, itis meaning inflammation. Because the only inflammation of cortex and marrow is infectious. In other places, like joints, arthro is joints, itis is inflammation. Well, there's rheumatoid arthritis, there's osteoarthritis, so we have to add a modifier and say septic arthritis. So we only add the modifier in places of the body where there's inflammation that's not infectious. In certain anatomic locations, like the disc space, there's no non-infectious causes. So we just say discitis. You got the rules for nomenclature? Okay. This would be osteomyelitis. We don't have to say septic osteomyelitis because it has to be infectious. There's no other cause. This would be septic tenosynovitis because there's a number of causes of tenosynovitis which are non-septic, just to give you examples of each of them. Now, soft tissue infections generally are called cellulitis or fasciitis, or if they're deep, pyomyositis. So pyo is the same as septic, is the same as infected. You could add any one of them. So pyo, purulent, myomuscle, itis inflammation. And we're going to speak about cellulitis and necrotizing fasciitis with gangrene, because they're all related to each other. So here we see soft tissue swelling of the fourth digit, no bone involvement, cellulitis. Right? Don't need a modifier, it's always infectious. And on MR, you'll see loss of the deep fat, and then when you get contrast, enhancement of the skin, septate, and vessels. Cellulitis, spreading infection of the extremities. It can be focal and rarely secondarily involves bone. Most of the time, musculoskeletal infections are a single organism. The notable exception is diabetic infections. And diabetic infections are polymicrobial. They're more than one organism. One difference between musculoskeletal infections and pulmonary or kidney infections is the virulence of the organism. Most of the time in musculoskeletal infections, there's a steady state between your immune system and the organism where the organism is just above your immune system. When you get a renal infection, you get pus in your urine. When you get a pneumonia, you have an infiltrate on chest x-ray, it's like this. Musculoskeletal, it's like that. Which makes the organisms difficult to culture. And a lot of times people mistakenly use the term sterile. For example, some of you have probably read, Brody's abscesses is sterile. Have any of you read or heard that? They're not sterile. There's bacterial DNA. It's just that the steady state is just like that. So it's really chronic. Which is why blood cultures are only positive in 20%. Now the most common organism is almost always staph, and the second most common organism is strep. And we'll talk a little bit about tuberculosis in a minute. In children and neonates, that's the same, except in neonates, E. coli is third, and in young children, if they haven't received vaccine, H. flu is third. In sickle cell disease, you may have read that, you can tell me this book, because this is many books, that salmonella is the most common organism, right? This is not true. Staph and salmonella are roughly equal. So you can pretty much always say that staph is the most common organism. This is just really severe cellulitis resulting in osteomyelitis. This was group E streptococcus. Septic arthritis, again, staph is always most common. Gonococcal is second most common. Intravenous drug users. The problem with intravenous drug users in Egypt? No? Yes. It's everywhere, unfortunately. It's staph followed by Pseudomonas. In the world, tuberculosis is the one-third of all musculoskeletal infections. In developed countries, it's 1%. How common is it here? We have different opinions. I'll show you. It's not rare in Detroit, to be honest. It wasn't rare in New York. Uncommon, but not rare. In septic arthritis, we'll talk about this in some detail. You'll see a joint effusion, enhancement, increased flow, increased blood flow, increased delayed, but the delayed should be warm, not hot. So anyone knows what this, and the most common organism here would be staph followed by gonococcus. And how about this? Anyone know the organism? Very good. Who said it? Very good. Tuberculosis. Have you seen this in Egypt? Oh, well, you're much younger than me. I've seen it twice. So I was giving this lecture at the University of Arkansas. And I showed, I have to give variations of this lecture for years. And I put this up, and the entire radiologist at unison yelled out spinal metatarsal. Because they're all from India. And they saw it the entire, because it's Arkansas, the radiologists were all from India. I thought it was kind of fun. Okay. How do infections get to bone? Hematogenous pathways, inoculatory pathways, adjacent spread, or iatrogenic. Hematogenous pathways are 3 categories of infections, and only 3. Almost all cases of discitis, almost all cases of septic arthritis, and almost all pediatric infections. Easy, but only like 10% of all musculoskeletal infections are those 3. 90% of infections occur in diabetics, and maybe 2% in paralyzed patients. And that's all inoculatory. And inoculatory means they have a soft tissue ulcer that also turned into a sinus tract. That sinus tract went to bone, and they got osteomyelitis. Direct spread is rare, and it's usually from the inside out. So septic arthritis could lead to osteomyelitis, but what's much more common is osteomyelitis leading to septic arthritis. And Cellulitis doesn't lead to osteomyelitis. Osteomyelitis leads to cellulitis. So when they spread directly, it's from deep to superficial. Post-op, 8% of spine surgeries get infected, 3% of joint replacements get infected, 0.1% of arthroplasties get infected, and 0.001% of arthrocenteses, which is a pretty high number, get infected. So this patient had a nail infection and a spread to the bone with osteomyelitis, very obvious on T1, very obvious on T2. This is the exception, not the rule. Most of the time, it spreads from bone to soft tissue. And here is osteomyelitis and septic arthritis. And typically, the osteomyelitis leads to septic arthritis. Iatrogenic. Patient had an MCL reconstruction. The surgeon inoculated the bone. And we see multiple abscesses in the bone where the surgeon inoculated the bone. So that's how infections get to the musculoskeletal system. But there's a specific pattern of how it spreads within the musculoskeletal system. So for example, when you get infections of the metacarpal phalangeal joints, it typically spreads to the flexor tendon, not the extensor tendon. If I get an infection of my fifth digit, that will spread to my carpal tunnel, but the second, third, and fourth will not. In the foot, the big toe and the little toe are separate compartments. So central infections spread proximally. The medial and lateral infections do not. And we'll show you sacroiliac joints because they have a very particular pattern of spread. Now you don't have to memorize this, but just understand that there are very frequent and reproducible patterns of spread. So this person had a metacarpal phalangeal joint septic arthritis, and we can see it spreading to both the flexor and extensor tendons. Sacroiliac joint osteoarthritis will spread anteriorly, then posteriorly, then through the greater sciatic notch to the hip, and then up to the spine. Always the same way. So here's a case with a sacroiliac joint infection and spread to the hip and spread to the spine. But always hip before spine. Always spreads distal before proximal. Now when you have osteomyelitis, the younger you are, the more likely it is to be at the end of bone. As you get older, it goes centrally in bone. So infants, epiphysis, children, metaphysis, young adults, metadiaphysis, older adults, diaphysis. So as you get older, it goes centrally in the bone. The second difference is children have looser periosteum. And that's why they heal better when they have fractures. But when they get osteomyelitis, they get subperiosteal abscesses, and adults don't get subperiosteal abscesses. So here's an infant with osteomyelitis of the epiphysis, which wasn't even fully ossified. We see the small area of ossification there. Here is a child with metaphyseal osteomyelitis, periosteal reaction because they have loose periosteum. So children will get subperiosteal abscesses and periosteal reaction, and adults will tend to get neither. Here's an MR of a different patient, but same age, metaphyseal osteomyelitis. So we did locations, we did organisms, we did hematogenous, which is children, disc-based and septic arthritis. The rest is mostly inoculatory, and the most common organism is almost always staph. And then we get osteomyelitis, where in the bone it is, and then we did patterns of spread once it's involved. Now let's go back to that nomenclature and show how each of them look on imaging. So this is going to be a lot of soft tissue swelling with cellulitis. And on CT, you'll see thickening of the skin. Your normal dorsum of your hand skin should be like parchment thick, like papyrus, perhaps. And then deep to it, when you get cellulitis, you'll get edema and replacement of the fat. So X-ray of cellulitis, CT of cellulitis, MR of cellulitis, the same thing, thickening of the skin, edema in the subcutaneous tissues, enhancement, and it looks like it's spreading. Doesn't it look like it's kind of overflowing, like a carbonated soda you're pouring into a cup? Maybe? That's what cellulitis looks like to me. And really, it's a spreading infection, and on imaging, it really looks like it's spreading. It's not contained. It's hard to see where it begins and where it ends. Now let's go deep. Fasciitis. Again, staph. This is older patients like cellulitis. Lower extremity more than upper extremity. And looks very similar to cellulitis except for the fascial involvement. So here's a CT, and we see skin thickening like we would see in cellulitis. We see reticulation of the subcutaneous fat like we would see in cellulitis. But look how the fascia is thickened. Can you see the fascial thickening? And that's different than cellulitis. So that makes it fasciitis. Cellulitis will usually be occult on indium. Fasciitis will be positive on indium. And on MR, you see the fluid in the fascia and the enhancement of the fascia. So the fascial involvement, as you would guess, distinguishes cellulitis from fasciitis. Now here is one that has cellulitis and fasciitis. Skin thickening, honeycombing of the skin, and fluid about the fascia. Never call this an abscess. A lot of times the fluid will even rim enhance. But if I turn a patient upside down, the fluid will go over here to the other side. And even though it rim enhances, it's not an abscess. Abscesses with fasciitis are very, very uncommon. Chances are everyone in this room together would see one in their career. It's very, very rare. Now, necrotizing fasciitis is the complication of fasciitis that we're all hyper-attuned to. Because if you miss it, the patient dies. If you overcall it, it's a horrible, horrible surgery. Have you ever seen the surgery? They basically open up the entire leg like this. And it's very cosmetically debilitating for the rest of the person's life. So you don't want to miss it. You don't want to overcall it. Now, most of the time, it looks just like fasciitis and cellulitis, with 3 to 4 exceptions. One is if you see gas, which, to be honest, you hope you don't see because they usually die when you see gas. It's a good sign, but not good for the patient. Second, you'll see muscle involvement. Typical fasciitis, typical cellulitis do not have muscle involvement. The more muscle involvement, the farther that muscle involvement is, the more likely it is to be necrotizing fasciitis. The third is deep fascial involvement, intermuscular fascia. And the fourth is lack of enhancement when you get punctures. And I'll show you examples of all of that. This is a case I saw many years ago. By the time I read the case and called the doctor, the patient had died. And I read it within 10, 15 minutes. So all this gas all around, they were on chemotherapy, common reason to get necrotizing fasciitis. And we see a lot of gas. It's very classic. Nice slide, very bad disease formation. Typical MR, you'll see the changes of cellulitis, the changes of fasciitis, but you see the muscle involvement. Will not see muscle involvement in typical fasciitis. And you give contrast, you see the enhancement of the vessels, and you see the no enhancement here. So that tells you that it's necrotizing. Another example, skin sloughing. Notice the deep muscle involvement. You see how much muscle involvement there is. Necrotizing fasciitis. Now, related to necrotizing fasciitis is gangrene. And the difference is gangrene is the tips of your extremities, the fingers and the toes, and necrotizing fasciitis is more proximal in your extremities. Now, dry gangrene is much more common than wet gangrene. And dry gangrene is basically ischemia to the 100th degree. And it's just dead bone and soft tissue from ischemia. Wet gangrene is an infection that includes vessels, and you get secondary ischemia. Wet and dry gangrene, if you see changes in bone, they look weird, and don't mistake them for osteo, because neither of them have an association with osteo. So this was a case my resident saw on call when I was in New York and called this osteomyelitis. So the nice thing is I have proof that it wasn't, because they amputated the foot. And I read it the next day and I said, aren't these little lobules of gas? Can you see the little lobules of gas on MR? And you see how it enhances here, and then nothing is enhancing distally. So this was wet gangrene, no osteo and histology. I told you see a lot of frostbite in Detroit. You see the loss of soft tissue, and you see the little gas. Do you see a little gas? Yes? And you see the lack of enhancement? Stops here. And this is now dry gangrene from ischemia, from frostbite. Another case of dry gangrene, but you see the changes in the bone? But the changes look odd. They don't look like osteo. They're more complex, more heterogeneous. Can you see that? And both dry and wet gangrene, when you get changes in bone, the bone is infarcted. And what you're really seeing is AVN in the bone. And that's why it looks weird. So we did cellulitis, we did fasciitis, we did necrotizing fasciitis, we did gangrene, and now we're going to do infectious myositis or pyomyositis. In the Western world, you see this in diabetics and patients on chemotherapy. In sub-Saharan Africa, which is not Egypt, I know, it's the most common surgical admission. Do you see it in Egypt, outside of diabetics and chemotherapy? So it is sub-Saharan Africa. It's staph, like all musculoskeletal infections. They tend to be minimally symptomatic, so they present as masses. And it's non-compartmental. Most tumors of muscle and soft tissue are compartmental. It's classically in the thumb. So let me show you some examples. So this was an intravenous drug user, and they didn't mount an immune response. They were chronically immunosuppressed. And you might call this necrotizing fasciitis because of the deep muscle involvement, right? But it's not contiguous. There's kind of a space between the two, which would make it unlikely. But this is pyomyositis, non-compartmental, non-mass-like edema in muscles. Usually thigh, sometimes upper arm. This is thigh. And can mimic a tumor, but not quite a tumor. This is another case, pyomyositis. This was a diabetic with a tibialis anterior. Pyomyositis, non-compartmental diabetics or patients, poorly controlled diabetics, I should say, or patients on chemotherapy. So we did skin, subcutaneous tissue, fascia, and muscle, and now let's do joints. Septic arthritis. If I have a bad left knee and a good right knee, which knee will get septic arthritis? Left knee? Correct. Now I have a bad L5-S1 disc space and a good L4-L5 disc space. Which will get discitis? L4-L5. And it's the same reason, because disc disease is avascular, right? It's ischemic. So I said septic arthritis is hematogous, right? It's one of the 3 hematogous infections. If it's ischemia, there's no blood supply, so I won't get a septic discitis. Arthritis is inflammatory, there's increased blood flow. So if I'm going to have septic emboli, they're going to go to an abnormal joint. So they're going to go to an arthritic joint, whether it's osteoarthritis, rheumatoid arthritis, gout, doesn't matter. It's the vascularity, not the type of arthritis. They cause effusions, almost always. So if you have a vacuum phenomenon, that means there's no effusion, that means there's no septic arthritis. Other than that, they look like rheumatoid arthritis, periarticular osteoporosis, uniform joint space loss, bare area erosions, just like you see in an inflammatory arthropathy, because it is an inflammatory arthropathy. What distinguishes it is, I'll give you all my orthopedic axioms, is any mono-inflammatory arthropathy is septic arthritis to tuberculous. So someone comes in with inflammation of their ankle and nowhere else, clinically you have to exclude septic arthritis. This case I just saw last week. IVDU, like we have a lot of in Detroit, joint effusion. But if you look here, the fluid is not parallel with the articular surface. I think it's hard to see, but it's not. It's kind of massive. I was kind of proud of myself. I called it septic arthritis, and it was Pseudomonas septic arthritis. Here's a patient. We see baseline film and then follow-up film. Can you see the destruction of the joint space? So uniform joint space loss, osteoporosis, and bare area erosion. Another one, baseline image, follow-up, septic arthritis. Baseline image, early erosions. Can you see the early erosions here? Follow-up, septic arthritis. So that's radiography. Joint effusion, periarticular osteoporosis, uniform joint space loss, bare area erosion. On scintigraphy, warm on all 3 phases. Positive but not hot. So here is an ankle joint. Could this be rheumatoid arthritis? Uniform joint space loss. Could this be rheumatoid arthritis? Certainly could. Here's the bone skin. Increased flow, increased blood pool, increased delay. Could it still be rheumatoid arthritis? No, it could, because it's only one ankle. Rheumatoid arthritis is never that asymmetric. So the radiograph could be, but the bone scan shows you it has to be septic arthritis. But if this was both ankles, this could be rheumatoid arthritis. Here's a hip, uniform joint space loss, obliteration, and warm on bone scan. Shouldn't be hot on bone scan. So that's X-ray, that's scintigraphy. How about MRI? MRI, you'll see, this is a contrast enhanced subtraction image, septic arthritis of the facet joint, distinction of recesses. It means an effusion under pressure, right? Distension of recesses means an effusion under pressure. Septic arthritis, uniform joint space loss. Do you see the bare area erosions? And on MR, kind of classic. Now, how do you distinguish reactive osseous changes from secondary osteomyelitis? And it's a very easy answer. It depends on how obvious the T1 is. The more obvious the T1 is, the more likely it is secondary osteomyelitis. So is this T1 obvious? Yes. And my rule is, If a first-year resident can see it, that's osteomyelitis. If it's anything more subtle than that, it's reactive. And every smiles when I say that, because everyone knows what that means. It's pretty standard. Dirty joint effusion. We spoke about this in the elbow. So not only will you see an effusion, it should be heterogeneous with a visible synovium sign and perisynovial edema. Again, septic arthritis, uniform joint space loss, you see it? Marrow edema, again, secondary osteomyelitis, obvious enough that a first-year resident can see it. Uniform joint space loss, loss of the subchondral white line, warm on bone scan. Now on MR, do you think the first-year resident can see this? The T1? Mezzo? So, I don't know. Again, I don't know what the answer is, but I think it's probably osteomyelitis. Okay, now related to septic arthritis is septic bursitis and septic tenosynovitis. But they are distinctly less common because if you put all your bursae and all your tendon sheets together, it's smaller than your knee joint, right? In volume. So it's just probability. There's not enough blood flow there to get many cases of septic bursitis or septic tenosynovitis. That's the only reason. They have a slightly increased incidence of TB. So if TB is 1% of musculoskeletal infections, maybe it's 2% of septic bursitis. So here's an example on X-ray with a markedly swollen olecranon bursa. This was septic bursitis. An ankle, septic lateral malleolar bursitis. A knee MR, fluid. Do you see all the edema and enhancement around the bursa, just like you see with septic arthritis? Visible synovium sign, just like you see with septic arthritis, but septic bursitis. And septic tenosynovitis, only can diagnose, in my opinion, with contrast, and only when you have more than one tendon visible. So here is enhancement of the posterior tibial tendon, see it here. But this could be rheumatoid, this could be reactive arthritis or Reiter syndrome. You don't know, it's just inflammatory tenosynovitis. So we went from skin to subcutaneous tissue to fascia to muscle to joint, now to cortex. And cortex we call osteitis because it receives shorter-term antibiotics than osteomyelitis. It's an ulcer that goes down to cortex with little medullary involvement. So here is a case, T1, T2, and post-contrast enhanced imaging. And this is abnormal on contrast, abnormal on T2, but normal on T1. So you would call this osteitis, and they should receive only 2 to 3 weeks of antibiotics. Here's another patient, here's the T2, and here's the T1. Would you call this abnormal on T1? No. They got 2 weeks of antibiotics and they did fine. So by one of the clinical definitions of osteomyelitis is failure to respond to 2 weeks of antibiotics. So if you do respond, then by definition. So this is osteitis. Now related to osteitis is a thing called an ulcer osteoma. An ulcer osteoma is this bizarre periosteal reaction because of an ulcer. Can you see the ulcer? Yes? Yes. And we see the ulcer osteoma. Now ulcer osteimas, the more irregular it is, the more likely they have osteomyelitis. The more regular it is, the more it is chronic inflammation. So here's the MR in this person. To me, this looks regular. Here's the osteoma, but there's no osteomyelitis. So this is an ulcer osteoma without osteomyelitis. This is an ulcer osteoma and another ulcer osteoma, obviously with osteomyelitis because the bone is gone. And this is another ulcer osteoma with osteomyelitis. But you can see that you have a Codman's triangle, it's much less regular. So a subtype of osteitis is ulcer osteomas, which is a chronic response to inflammation from the infection. So now let's go to osteomyelitis. So osteomyelitis, I'm going to start out with X-ray. The X-ray changes lag by 14 days. It's typically hematologous in children, but inoculatory in adults. Children more than adults get periosteal reaction. Most of the time you see bone rarefication and lysis. So here are two examples: a child with osteomyelitis, bone destruction and periosteal reaction; an adult with osteomyelitis, permeative and no periosteal reaction. So osteomyelitis will look different depending on your age. 8 days apart, we see an ulcer in the soft tissues of the toe, some early destruction of the tuft, and then within 8 days the tuft is mostly destroyed. Another one, early destruction, really soft tissue swelling and an ulcer only, and now you see the bone destruction. Typical adults, hematogenous diaphyseal. Here's a cone down image where you see the permeative appearance of bone without a periosteal reaction. So radiography, late, adults permeative, later bone destruction, children, more lytic, more periosteal reaction. Scintigraphy, not warm on all three phases, hot on all three phases. And you can use white cell agents except when it's a chronic infection, and then you use gallium. So here's a patient, I think even in retrospect has a normal X-ray, and the bone scan is hot, just showing you that the radiographic changes lab. Just for the sake of completeness, a PET scan of osteomyelitis. MRI, we've shown you a few examples already, low on T1 so that a first-year resident can see it, high on T2. You won't see a periosteal reaction on X-ray, but you will see a periosteal reaction on MR, and I'll show you how to look at it. And osteomyelitis tends to entrap fat. We'll talk about the entrapped fat sign in a minute. So, not very subtle, marrow replacement on T1, marrow edema on T2, standard diabetic with osteomyelitis. T1, T2 post-contrast, here's your ulcer, here's your marrow replacement, and note the area of non-enhancement on contrast. Not gangrene, but needs to be debrided because antibiotics won't get there. Gallium is a plasma agent. Gadolinium is a plasma agent. So is gallium, but gadolinium is a plasma agent, and antibiotics are plasma agents. So if gadolinium doesn't get there, antibiotics won't get there. This patient had a tibial fracture with a malunion, has infection following trauma with abnormal T1, abnormal T2 osteomyelitis. Now the entrapped fat sign. We talked about yesterday that tumors push marrow, and most causes of edema sprinkle throughout the marrow. Osteomyelitis is in between. It has a bit of tumor to it, but it's not neoplastic. So it'll push marrow and then skip around marrow and push and skip around. And that leads to a thing called the entrapped fat sign. Here's an example of one in a child. This is a T1, this is a T2, this is post-contrast. This is a subperiosteal abscess. Can you see the subperiosteal abscess? and we see a fat fluid layer in the subperiosteal. So not uncommon to see these entrapped fat and infections, but typically it's in the marrow. So here's osteomyelitis. You see the globules of fat entrapped within this? So remember, tumors are bulldozers, and most edema sprinkles, but osteomyelitis is in between. It's a bulldozer that skips, a bulldozer that skips, and you'll get the entrapped fat sign. Here's one final example, inversion recovery image. So this is a lobule of fat which is suppressed in the osteomyelitis of the humerus. This was fungal osteomyelitis. Okay, surgical planning. Where do they amputate and when do they amputate? So if there's decreased enhancement, you need an amputation. If you're going to do an amputation, you amputate only the T1 weighted abdomen, not the T2, not the gadolinium. The T2 and the gadolinium will respond to intravenous antibiotics. So you only amputate what's abnormal, and again, first year resident abnormal on T1. Now I'm going to tell you another surprising fact. The more you amputate, the higher the risk of recurrent infection. Let me say that again. The more you amputate, the higher the risk of recurrent infection. Because every time you ambulate, the energy is dissipated over a smaller area, and you get more ulcers following that amputation. So you get more recurrent infection. So if you want to preserve the patient from getting recurrent infection, you want to do limited amputation. So here is T1, here is T2, and this is where they amputate. Chronic osteomyelitis. Femur greater than tibia. But remember, many diabetic feet really have chronic osteomyelitis. In America, it's often immigrants. They show signs of healing with sclerosis and organized periosteal reaction. And a lot of times you see cortical defects, those who are iatrogenic from previous surgical decompression. So here's an example. Chronic osteomyelitis, sclerosis, cortical thickening. Do you see the defect? And we see defects because it's been going on for 20 years, and sometime along that time the surgeon went in and did decortication to penetrate it. More chronic osteomyelitis in the femur. It looks like osteo, but the cortex is thick. There's an organized periosteal reaction, and we call that organized periosteal reaction involucrum. Tibial malunion, infected, and you can see the abscess here, and hot on bone skin. Chronic osteomyelitis. They all begin to look the same. Chronic osteomyelitis. Now the signs we look for are a sinus tract, a cloaca, an involucrum, and a sequestrum. We'll talk about that in a minute, but just as a preview. The cloaca is a tract that goes to a non-epithelial structure. So from cortex to muscle is a cloaca. If it goes from cortex to skin, cortex to bladder, that's a sinus tract. So if it goes to a epithelial line, it's a sinus tract. The sequestrum is a nidus of dead bone. I'll show you examples of that. The involucrum is the organized periosteal reaction. So here's a subperiosteal abscess, a cloaca, more than one cloaca, and chronic osteomyelitis. You'd be suspicious that there was a sequestrum here. I don't remember, to be honest. Chronic osteomyelitis of the calcaneus. And what do we see centrally within this? Sequestrum. And the importance of sequestrum is it's a petri dish for the bacteria. It's putting out their favorite food to eat, and as much as they want to eat, so they're never going to go away. So you got to take out the sequestrum or the infection or never resolve. So let's talk about abscesses. You can get subperiosteal abscesses, which I showed you, intramedullary abscesses, acute or chronic, the chronic called a Brody's abscess, soft tissue abscesses, think of non-pyogenic infections, and if they're small, diabetes. Those are the types of abscesses that we can have. So here are multiple muscle abscesses. Can you see the rim enhancement? A skin abscess, subcutaneous I should say. Patient had chronic osteomyelitis and a good subperiosteal abscess. Can you see the big subperiosteal abscess? Which they took out and put antibiotic and impregnated beads. Intramedullary abscess. Not Brody's, because there's edema around it, which tells you it's a relatively acute abscess. Brody's are by definition non-acute abscesses. A subperiosteal abscess, typically this would be seen in children. An intramedullary abscess, rim enhancement, also typically in children. And epidural abscesses tend to have less rim enhancement. They tend to look somewhat more phlegmatish than abscesses, but at surgery they're still abscesses. So Brody's abscesses are distinct because they've been there for 10 to 20 years. They're an abscess that steady state between the organism and yourself is just ever so slightly favored in the organism's favor. They're metaphyseal. You'll see a tract going to the physis, and they should have sclerosis, variable amounts of sclerosis, and they're not sterile. You're just not able to culture an organism. There are organisms there, but they're just so fastidious you can't culture them. Here's a Brody's abscess in the tibia, and you can see the tract down to the physis. A Brody's abscess in the ilium, been there for a long time with sclerosis around it. A non-ossifying fibroma, which is why we did the MR, interestingly enough, but has a Brody's abscess where they tract down to the physis. Having a non-ossifying fibroma was the best thing to happen to the patient. Okay, so we did chronic infections and abscesses, and they're all related to infection complications. We talked about a sequestrum already. That's a nidus of dead bone in an area of infection. We talked about the involucrum already. That's the chronic periosteal reaction. We talked about the cloaca already. That's the sinus tract that goes to a non-epithelial structure. And we talked about sinus tracts that go to skin. And we spoke about abscesses. The one thing we didn't speak about is a felon. And remember I talked about wet gangrene earlier. And wet gangrene is an infection that leads to ischemia, right? A felon is related to that. It's an infection that the mass effect includes venous drainage. So your veins can't drain. So you get ischemia. So a wet gangrene is arterial ischemia. A felon is venous ischemia. So chronic osteomyelitis with involucrum. So here is a felon. Soft tissue mass and secondarily eroding bone and a lot of soft tissue swelling. So it begins in soft tissue as an infection, walls off because of the mass effect, decreases venous drainage, and leads to infarction. And here's another felon, always in the tips of the fingers. Yet another one. And a sequestrum, a cloaca, and an involucrum on CT. So two peculiar infections before we get to TB and parasites. Sclerosing osteomyelitis of Garay is just chronic osteomyelitis with a lot of sclerosis. Fancy name. I think it was the first paper I ever wrote when I was a resident, but really of no interest. Described in the tibia and the mandible. Chronic recurrent multifocal osteomyelitis, perhaps not even osteomyelitis, perhaps some plasma cell disorder with reactive changes, seen in the metaphysis and the clavicle. An example of it here in the metaphysis, CRMO. Disc space infection, as I said earlier, hematogenous, analogous to septic arthritis. You'll get bare area erosions, you'll get uniform disc space height loss, and you'll get the equivalent of an infusion, which is epidural spread. Disc space infection, uniform joint disc space height loss, fluid in the disc space, and then abnormal marrow in the adjacent vertebral bodies. Classically, it only involves half of the vertebral bodies, and the term is hemispherical sclerosis. Another case of disc space infection. What is peculiar about this one? It's L5S1. Disc space infections go to normal discs. L5S1 is the most commonly degenerated disc. So it's unusual to have a disc space infection at a normal disc. Now we're going to speak about TB momentarily, but I wanted to talk about a thing called neuropathic spine. And neuropathic spine mimics a disc space infection. It's seen in diabetics. And the way you distinguish it is how irregular the end plates are and involvement of the facet joint. So this patient has a typical disc space infection, atypical that is spreading to adjacent levels, but uniform disc space height loss, fluid in the disc spaces, nothing in the posterior elements. This person has an atypical infection with an anterolisthesis, no fluid in the disc space, but marrow-edema on either side. And this was a diabetic, so this is neuropathic spine, but could just be a degenerated disc. This is neuropathic spine. This was an intravenous drug abuser. And again, you see how irregular the end plates are? They're beyond erosions. Do you see how the facet joints are involved? So irregularity in the end plates and facet joint involvement distinguish neuropathic spine from infection. Another neuropathic spine can look very much like infections like that. Okay, we're going to finish before reviewing with TB. TB and atypical. So TB, massive worldwide frequency, although not that common in Asia. They always have lung disease. So the chest x-ray will show changes of prior TB, not active, but changes of prior TB with calcification. But the spread to the musculoskeletal system comes from the genital urinary system. So it goes from the lungs to the kidney, from the kidney to the bones. That's typical TB. And it looks like chronic osteomyelitis. So osteomyelitis has kind of a healing, chronic osteomyelitis has a healing response. Tuberculosis has a healing response. And it lacks collagenase. We spent a lot of time talking about collagen. What causes the uniform joint space loss in septic arthritis is pyogenic organisms have collagenase. What causes the uniform disc space height loss in discitis is pyogenic organisms have collagenase and they destroy the disc uniformly. Tuberculosis and parasites lack collagenase. So you don't see uniform joint space. Difference number one. Difference number two is the erosions tend to be more marginal than bare area. Said septic arthritis looks like any other inflammatory arthropathy except it's monoarticular. Tuberculosis gives you more marginal erosions, more like gout or MI. And that's called Femistis triad if you add in periarticular osteoporosis. So this person had TB septic arthritis, no joint space loss, marginal erosions, and periarticular osteoporosis, tuberculous septic arthritis. In the spine, because you don't get uniform disc space height loss, you get anterior disc space height loss, and you get a gibbous deformity. When pyogenic organisms give you uniform disc space height loss. So this gibbous deformity is TB spondylitis. Another case of TB septic arthritis. Note that the joint is no loss of joint space. Marginal erosions, and do you see the sclerosis? Yes? Sign of healing. The TB is a chronic infection. X-ray and corresponding T1 MR. Normal door joint space, marginal erosions of massive. Femistis triad tuberculosis. This was Mycobacterium marinarum, so a different kind of tuberculous agent from a guy who had a fish tank and got contaminated by feeding his fish without gloves. No loss of joint space. No, it's other than the osteoarthritis here. No loss of joint space, non-pyogenic arthritis. Another case of Mycobacterium marinarum, complete destruction of the wrist on T1 and T2. Now in the spine, it's non-uniform, so it affects the anterior aspect of the disc space. It more commonly involves more than one level, and you tend to get perispinal abscesses that you don't get in pyogenic organisms. So tuberculosis of the spine with large perispinal abscesses. So let me review what we talked about so people have time to go to prayer. We began with the definitions. We said itis means inflammation. The base of the word is the part of the body involved. And if there's inflammation that's non-infectious, then we have to say a modifier in front of the word like septic or purulent or pyogenic. And then we said the most common organism is almost always staph. The second most common is strep, except in sickle cell where it's salmonella, and in septic arthritis, at least in America, where it's gonococcal. We said pyogenic organisms have collagenase, so they cause uniform joint space loss in joints and uniform disc space height loss in spine. The atypical organisms like tuberculosis lack collagenase, so they don't do that. We said in infants, osteomyelitis begins in the epiphysis. In children, it's in the metaphysis. In adults, it's the metadiaphysis or the diaphysis. But children also get more periosteal reaction than adults do, and more lysis than adults do. We said the only hematogenic infections are septic arthritis, disc space infections, and pediatric infections. Most other infections are directly inoculatory. Then we tried to distinguish between wet and gangrene, wet and dry gangrene, with dry gangrene being ischemia much more common, but they both give you these weird bone changes that you shouldn't confuse with osteomyelitis because they rarely have osteomyelitis. Then we went through cellulitis, fasciitis, necrotizing fasciitis, no enhancement, fluid in fascia between muscles, muscle involvement far from skin, and air if you happen to be able to see it. Septic arthritis always has effusions, uniform joint space loss that we said. Osteomyelitis we went through, but stress the and trap fat sign. Chronic osteomyelitis, look for sequestrums and involucrums, but other than that, just shows evidence of healing with a periosteal reaction and sclerosis, and often defects where the patient was previously drained. But tuberculosis and other non-pyogenic organisms can look very much like chronic infection. Okay, thank you very much.
Thank you very much, Mark, for your elaborate presentation, and also for giving us some time to catch Goma very time. Any question, directed question to Dr. Schweitzer. Thank you very much.
الكوفي بريك بتتجمع على البريك لاين، فمفيش حاجه سيبريت. يعني